Hello again, and welcome to yet another episode of APHA's 15 on COVID-19 series. Today we'll be talking about IL-6 antagonists and their role in COVID-19. My name is Dan Zlott. I'm the Vice President of Education at APHA. Thank you once again for joining us for our April 6th episode. Without further ado, let's go ahead and dive in. As usual, I have nothing to disclose. The learning objectives for today: at the end of this activity, you should be able to discuss the latest developments related to COVID-19. All right, so as we start talking about IL-6 antagonists, it's important to understand the background, why we're talking about essentially immune modulators. And so with that, let's take a look at some of the immune-related complications that we've seen in COVID-19. So as more evidence has emerged from patients with COVID-19, it's becoming increasingly clear that many of the severe symptoms of COVID-19 are actually, we think, caused by the immune system and the immune system's reaction to the virus. There's not a lot of evidence for direct damage to the organs. There's some, but really the severe complications, the life-threatening complications, it appears are a result of our immune system reaction to the virus. So post-mortem or autopsy results confirm the presence of highly activated immune cells in lung tissue in particular. They were also seen in heart tissue, myocardium, and then on occasion in other organs. They also confirm high levels of activated immune cells in the blood, and in particular, the immune cells were noted to have high concentrations of cytotoxic granules in them. So these are mostly T cells that we're talking about. T cells are one of the things that we think are highly upregulated in this immune response to COVID-19, as well as some of the damage that it's caused by the immune system in response to the virus. And so the authors of this particular autopsy report concluded that the findings are consistent with immune damage, and this was particularly true of the damage that they observed in the lung tissue. They saw pretty classic findings of ARDS, as well as, again, that infiltrate of highly activated T cells, mostly in the lungs. So pretty strong evidence that there's a really potent immune response going on, and that immune response is actually what's causing the tissue damage or the tissue injury that the pathologists were seeing. So as I just mentioned, it's pretty clear that there's mounting evidence that a lot of these severe symptoms is caused by immune-mediated organ damage. And so as we've continued to explore what's been going on in these patients, people have started to look at markers of inflammation or markers of immune activity. And what we've seen is that there have been multiple studies done, mostly coming out of China, but they indicate significant elevation of a number of pro-inflammatory biomarkers. In particular, IL-2, or in this case, the IL-2 receptor, which is a solubilized form of the IL-2 receptor, interleukin-6, interleukin-2, and tumor necrosis factor alpha. And in this particular study, the authors were trying to identify the cytokine profile that separates patients with moderate disease from patients that have severe disease. And what they discovered was that there were statistically significant differences in the levels of these particular cytokines. Again, that's IL-2, IL-6, IL-10, and tumor necrosis factor alpha between moderately and severely ill patients with COVID-19. So at least in this study, it looked like these were some of the key cytokines that were elevated. Now, it's important to understand that just because they're elevated doesn't necessarily indicate a causative relationship. So this could just be the effect of the infection. It may not be the cause of some of the severe symptoms. So that's an important distinction, and we'll try to highlight that as we go through. So what are again, let's take another look at a different aspect of these immune-mediated complications of COVID-19. And we're going to transition just a little bit. We're maybe going to look at something that might seem a little bit tangential at first, but we'll bring it back around and hopefully you'll see the connection. So let's talk a little bit about a phenomenon called cytokine release syndrome. Cytokine release syndrome is a systemic inflammatory response, which results in a lot of pretty severe symptoms depending on how potent the response is. And one of the first ones that we see is vasodilation. So we see significant vasodilation, especially in the capillary beds. And this results, we think, in increased vascular permeability, or also known as capillary leak. So you have all the volume that's typically in the intravascular space extravasating into the extravascular space, into organs, into peripheral tissue, etc. This can also result in hypotension. So again, think about it. You've got vasodilation, so your blood vessels are opening up. Additionally, you're potentially losing volume, and so it's not easy. It's not hard to make the connection between hypotension and some of those other symptoms. Additionally, because of the edema, because of that extravasation of the intravascular fluid, you start to see increased interstitial fluid buildup, both in organs and in the peripheral tissue, as I mentioned. And in the case of COVID-19, that's particularly problematic in the lungs, where we see a lot of pulmonary edema. Keep in mind the function of your lungs is to exchange oxygen and carbon dioxide. And they do that by having a relatively small space between the blood vessels and the alveoli so that that gas exchange can happen. As more fluid builds up in there, that gas exchange is inhibited. And so obviously that is problematic for our lungs, and we start to have issues with gas exchange. And that's exactly what you see in COVID-19. Additionally, as a result of the hypotension and potentially as a result of other direct cytokine effects, you also see progressive, or you can see at least progressive organ damage. And that can be anything from renal failure, hepatic failure, etc. And so those are probably some of the more common things that you see in terms of organ damage, but it's all sort of a cascading series of events, and these things are all interlinked. So why are we talking so much about cytokine release syndrome? Well, it turns out there's a lot of hypotheses floating out there that we actually are seeing a form of cytokine release syndrome in patients with severe complications from COVID-19. So how do we get to IL-6 from all this? Well, let's take a look here. It turns out that cytokine release syndrome is a phenomenon that we commonly see in immunotherapy for cancer. In particular, there's a significant amount of, or significant incidence of cytokine release syndrome for a relatively new class of treatments called chimeric antigen receptor T cell therapy, or CAR T therapy. And so these are T cells that have been taken out of the body, genetically modified to express an unusual variant of a T cell receptor. That's a topic for another day. We won't go into that. However, when those cells are reinfused, it's not uncommon for patients to have cytokine release syndrome, and it can be pretty severe. We used to see this a lot at National Institutes of Health, where I used to work prior to joining APHA. And it turns out that we've, over time, have gotten a better profile of the cytokines involved in cytokine release syndrome. And here's the list. It's not inclusive, and you'll find different results depending on exactly which study you read, but these are the ones that tend to come up over and over again. Tumor necrosis factor alpha, interferon gamma, interleukin 1b, IL-2, IL-6, IL-10, IL-8, and sometimes IL-12. Depending again on which piece of literature you read. So if you remember from the previous slide, there's a lot of repeats here, right? Tumor necrosis factor alpha, IL-2, IL-8, IL-10, and of course IL-6. So it turns out we've been looking for a long time for ways to help counteract the effects of cytokine release syndrome in this CAR T therapy. And one of the treatments that's emerged as being very effective is tocilizumab. Tocilizumab was approved by the FDA for the treatment of severe cytokine release syndrome in CAR T cell patients. And that's important for a couple of reasons. So CAR T therapy is based on the idea that we're generating an immune response against cancer. At the same time, cytokine release syndrome is, we think, a super potent, or an immune response that's inappropriately strong. And so we're trying to find this needle, this little narrow space that we're trying to get through, where we're able to control the acute reaction, the cytokine release syndrome, without compromising the immune system's response to cancer that we're trying to treat with CAR T therapy. And it turns out that tocilizumab is able to do this. And again, that's something analogous to what we're seeing with COVID-19, right? We are looking to quiet down a very potent, inappropriately potent immune response to COVID-19, to the virus that causes COVID-19. At the same time, we don't want to cause total immunosuppression. That's obviously a very bad thing in the setting of infection. And so based on our experience with cytokine release syndrome in CAR T patients, people are thinking that tocilizumab is a great tool to be able to shut down this acute cytokine-driven response to COVID-19 while still not suppressing the immune response that we want to help the body combat the viral infection. So that's where a lot of the interest is from. And so, of course, a lot of people have been hypothesizing that IL-6 antagonists like tocilizumab may be efficacious in treating COVID-19. So is there any evidence for this? Well, it turns out that there's some. It's not great, like most things COVID-19. So let's take a look at what there is. So this is a trial, and I use the term trial very loosely. It's somewhere between a clinical trial and a case series. So I'm really not quite sure where exactly it lands, but it's, again, somewhere between those two. So this is an open label trial in 21 patients in 2 hospitals in China who had confirmed COVID-19 with severe or critical symptoms. And they define severe or critical as having a respiratory rate greater than 30 breaths a minute, having an O2 sat of less than 93% on room air, having an arterial oxygen over inhaled FiO2 or fraction inhaled of O2 score of less than 300. And so that, depending on which scale you look at, if you're looking at the Berlin criteria for ARDS, that's the criteria for mild ARDS, and it gets worse from there. So that's the severe category. Critical patients were listed as having basically needing mechanical ventilation, shock, ICU admission with organ failure. So those were the patients who were defined critical. So the intervention, patients received tocilizumab 400 milligrams IV times 1, except for 3 patients who had a second infusion within 12 hours because they had a fever during the first infusion. And so that was the intervention. After treatment, the investigators reported that the patient's temperature returned to normal the day after receiving tocilizumab and remained stable for all patients. So in other words, almost basically within 24 hours, immediate resolution of patients' fevers. And then I'm going to quote directly from the paper. Clinical symptoms were significantly relieved synchronously in the following days. I'm not entirely sure what that means, and I'm also not sure of the exact time course of symptom resolution. There was some data in the paper, but it wasn't really well spelled out. This is kind of why I say it's somewhere between a case series and a clinical trial. The data was a little fuzzy, and it was presented in very broad general terms. So again, continuing on with the clinical efficacy from this trial, O2 saturation was improved, and here we do have more specific data. 1 patient was able to discontinue oxygen supplementation via nasal cannula. 15 patients had lower O2 requirements, so if they were either on the vent or if they had a nasal cannula, the O2 flow rate or the FiO2 was able to be decreased. 1 patient came off the ventilator the day after receiving tocilizumab. 1 patient was extubated 5 days after receiving tocilizumab. Another patient who had previously been given invasive ventilation had lowered the parameters of the ventilator and expected to be off the ventilator shortly. Again, I'm quoting directly from the paper there. So showing signs of improvement, but still intubated and requiring ventilator support. On imaging, the imaging findings showed that CT scan. This was on CT scans, and the imaging was done at baseline and then 1 week after starting tocilizumab therapy, and it showed that the lesions were absorbed in 19 patients, which is another way of saying that the pulmonary infiltrates you see on CT scans in patients with COVID-19 resolved in a little over 90% of the patients in this very small trial. In terms of general outcomes, the authors reported that 19 patients were discharged from the hospital, so 19 out of 21 at the end of this little case series. The average length of stay was 13.5 days, plus or minus 3 days, after the tocilizumab administration. and there were no adverse events reported from the administration of tocilizumab, so relatively well tolerated. Additionally, there were no reports of pulmonary infection, deterioration, or death in those patients who received tocilizumab. So on the whole, it sounds like this is pretty positive, pretty good outcomes, particularly considering these are patients who were at severe or critical, basically who had, moderate to severe COVID-19 disease. The caveat here, of course, is this is an open label trial. There are no controls, and so it's difficult for us to know how these patients would have done had they not received tocilizumab. So that's the big caveat to all of this. And then, of course, just generally, again, the data is somewhat descriptive and is not terribly precise. So difficult to fully understand this, but on the whole, this sounds like a relatively positive trial. Another case report. This is in a 56-year-old male with end-stage renal disease who was on hemodialysis. He had a past medical history that was significant for coronary artery disease. He had ischemic cardiomyopathy, and he was status post percutaneous coronary intervention to his left anterior descending artery and right coronary arteries. So significant cardiac history there, a patient who would be considered to be at pretty high risk. He was on losartan 100 milligrams every day at the time of presentation. And he bounced in and out of healthcare systems and emergency rooms for a couple days before he landed in this particular hospital. So upon admission, he'd been having GI symptoms and fevers for about 5 days. His chest x-ray on admission showed patchy opacities. The chest x-ray he had upon his first encounter with healthcare, which was maybe 5 or 6 days prior to this, didn't show anything. So he'd been having symptoms for about 5 days by the time he showed up. And again, those patchy opacities were in both lungs. So the patient underwent hemodialysis on hospital day 2 after he was admitted on the second day, and did okay with that. He didn't tolerate it terribly well, but then overnight between hospital day 2 and day 3, the patient's respiratory condition deteriorated significantly. He was intubated and transferred to the ICU. And sometime over the next 24 hours, he developed ARDS and required aggressive ventilation as well as pressor support. So this is a guy who needs serious help. He was also started on CVVH. Again, keep in mind, he also had some baseline renal dysfunction that required him to be on hemodialysis. So the combination of respiratory issues along with renal failure, not a good combination for managing oxygenation and pH status. So that's why they chose to start him on CVVH. He was also started on hydroxychloroquine. The exact day of start of hydroxychloroquine was not mentioned in the paper. We do know that he received tocilizumab on hospital day 6. They did not report the dose that he received. And the case report ends 5 days later, so basically on hospital day 11, and the patient was still intubated. He required aggressive ventilation as well as pressor support. The authors mentioned they were considering ECMO, and that's where the story ends. So this is a patient who's at significant risk, has a number of risk factors, but the outcome there was not quite as positive as what was described in the Chinese experience. So again, it's a case report. It's an N of 1, so you have to take that with an appropriately sized grain of salt. So I was able to find one more case report, and this was a 42-year-old male who was recently diagnosed with metastatic renal cell carcinoma, relatively rare form of kidney cancer. He was hospitalized for fever, bone metastases, pain, and general management. I think they were trying to decide how to manage his newly diagnosed renal cell carcinoma. On hospital day 6, the patient develops a mild cough and fever. So again, he had fever at baseline. It's unclear whether he was febrile from day 1 all the way through hospital day 6. The authors didn't really get into that. But on day 6, he develops a mild cough and his fever is definitely present. At that point, the patient is confirmed to have COVID-19. And so he started on lopinavir ritonavir on hospital day 7, and he maintains that treatment course for 5 days. And then on hospital day 8, the patient develops dyspnea and he drops his O2 sats, and he requires supplemental O2 via nasal cannula at a rate of 6 liters per minute. So not super aggressive. He didn't need to be intubated, but he definitely required some oxygen supplementation. He was also on hospital day 8, receives tocilizumab 8 milligrams per kilogram IV every 8 hours times 2 doses. And so the authors reported rapid clinical improvement within 24 hours. The patient is afebrile. Again, that's similar to what was described in the Chinese experience. And he had decreased O2 requirements. His O2 supplementation was discontinued on day 12, so 4 days later. And then, of course, the CT on hospital day 12 confirmed improvement in the pulmonary infiltrates that they found. So the image there, there's a CT scan from day 6 and from hospital day 12. And if you're not used to looking at CT scans, those may not look all that different, but the day 12 image shows significant improvement of the consolidation there in the left lung. Keep in mind, it's reversed. So when I say left, look at the image on the right. But there's significant improvement there in the CT scan. So this one's a pretty positive outcome. And the patient fully recovered from COVID-19 symptoms. They didn't mention anything about discharge, but they did mention that he fully recovered. So that's the available clinical literature or clinical data that I was able to find. So with that, the bottom line. Should we be recommending IL-6 antagonists for COVID-19 disease? As with so many other treatments for COVID-19, the data to support the use is really what I would call descriptive only. Even the study, quote unquote, from China, as I said, I really consider that more of a case series than a true study. There are a number of clinical trials started to examine the use of IL-6 antagonists in COVID-19 in a more controlled fashion. So again, as with everything else, keep your eye on this. I suspect there'll be more information coming out quickly. One thing we do know for sure is that tocilizumab therapy is very well tolerated. It's an FDA-approved medication. It's used for several autoimmune diseases. It's approved for cytokine release syndrome, so we know it's well tolerated even in critically ill patients. And as always, until we get more information, it's about risk benefit. So if you think about who the patient population is here, these are patients who are at significant risk. They have moderate or even severe COVID-19 disease. And so there we're looking at maneuvers that we can do that will rapidly change the course of COVID-19 disease. And so there, the risk may be less because they're already in a bad place. And so maybe there's more benefit to be had. So again, it all depends on the particular situation. There's a lot of other considerations related to tocilizumab in terms of availability. It's certainly on shortage right now. The entire world is looking at using tocilizumab, so it's becoming difficult to find. So again, benefit versus risk. On the whole, I'd say there's some evidence supporting benefit. Again, this is at a very at-risk population who are in bad shape, kind of more of the severe COVID-19 patients. So, sorry to be inconclusive. Unfortunately, that is the nature of a situation like this where data is literally emerging day by day. So with that will wrap up today's 15 on COVID-19 series. I see we went a little long again. I hope you found the information useful in terms of helping you understand why people are so interested in IL-6 antagonists in COVID-19 disease and sort of how we arrived at the use of tocilizumab in particular. If you have questions about COVID-19, please keep them coming our way. We've been getting a lot of great questions. We are excited to be able to answer your questions. And quite frankly, we can't get enough information out as quickly as you guys need it, but we will keep trying. So our next 15 on COVID-19 episode will be released on Friday, and it will be looking at testing modalities for COVID-19. There's been a lot of questions there, a lot of developments, so we'll try to talk about the different types of tests that are available and give you a little bit of insight into how those work. Until then, if you do have questions, please email us at covided@aphanet.org, and we look forward to seeing you on Friday.